Thank you very much. Good afternoon. When hypomethylating agents fail is quite a challenging topic that I have received from the organizers, and I'm not very sure if I can answer this question to the last final point, but I think that what I try to do is to talk about the road we are on and maybe about the directions that we will follow. These are my disclosures. Due to the nature of this topic, I will discuss off-label use of drugs. And I have to add a disclaimer. Due to the time allocated for this talk, I have not the time to cover every compound in MDS that is currently being tested in clinical trials. I had to make a selection. Selection is based on the level of evidence. That means if we have randomized data, which are quite a few, but they are important, we'll discuss this data. And then there is a selection which is subjective, and I have to apologize if I do not cover some other drugs. So what is this all about? It's about treatment of high-risk MDS, and what is the state of the art? What are the guidelines telling us in this regard? I have chosen the NCCN guidelines here for this slide, but there are no real differences to guidelines from other societies. And as you see, it's the main point. The first question is the patient fit for an allogeneic stem cell transplant? And if so, do we have a donor or a stem cell source? And then we shall go on to the allotransplant, and we have to answer different questions. Do we transplant right on, or do we use azacitidine or intensive chemotherapy? And all these topics will be covered by the next speaker. But we have to confess that the majority of patients do not fit into this scheme, and therefore they go for conventional treatment, and conventional treatment according to the NCCN guidelines is hypomethylating agent, where azacitidine is preferred to decitabine, both agents licensed in the US, and in Europe there's only one licensed agent, this is azacitidine. So if this is the only current option, we need to have a look what this agent is able to do with our patients, and I'm sure that you are all familiar with the data shown on this slide. This is from the registration trial, and it shows with azacitidine an impressive prolongation of overall survival of more than 9 months compared to conventional care regimens, best supportive care, intensive chemotherapy, or low-dose low-dose RRC according to physician discretion. And this means overall survival at 2 years of 50.8% versus 26.2% in the conventional treatment arm. This is, of course, an impressive overall benefit, but not all patients can be content with this, and we need to move on and improve above this. And what we also have learned that the remission rates are rather low for CR and PR, but if you have a hematologic improvement, then you have this overall survival benefit, and this is clinically meaningful, also in terms of quality of life, what you have heard already from Fabio Efficace. But the outcome with hypomethylating agents is 40 to 50% do not respond, and most responders progress beyond 1 to 2 years. And the question is what to do with those patients. And the data that we have at present are rather disappointing. There are 2 publications, one from the French group with azacitidine, and the other one from MD Anderson with azacitidine and decitabine, mainly the same outcome. The French series reports about more than 400 patients, and the median overall survival after azacitidine failure is 5.6 months. And the factors that negatively impact this survival is age, cytogenetic risks, bone marrow blast count before azacitidine, male sex, and no response to azacitidine. That means if you have a primary or secondary azacitidine failure. The approaches that were followed after azacitidine failure, supportive care, low-dose chemotherapy, intensive chemotherapy, investigational treatment, and also stem cell transplantations. And as you can see, the longest survival curves, long survival times can be seen after stem cell transplantation. What are possible strategies? Of course, it is wise to maintain hypomethylating agent treatment in responders, not to stop this treatment, because we have learned that if you stop the treatment and if you try to start again in responders, that you have very bad results. There are 2 small case series documenting this, but it's also the clinical experience. The median progression-free survival with discontinuation is 4 months or 5.4 months in the other publication. You can use other hypomethylating agents, you can use chemotherapy, transplantation, and other targets, and those are the different possibilities that I will cover in the next few minutes. Other hypomethylating agents, can you use the other licensed or at least FDA licensed drug after AZA failure? We have limited data. The largest case series is again from the French group with 36 patients, and the overall response rate in this population is 19% with a short progression-free survival and overall survival. There are new hypomethylating agents on the horizon that are being tested first line or after AZA failure. And for Rigosertib, which is a prodrug, we have phase 1 data in relapsed and refractory AML and MDS with a response in 6.19 MDS. So you will hear from me for many of these early publications, we need more data and should assess this in clinical trials. The other compound is Azacitidine, where we have phase 2 data in elderly AML, first line and relapsed, with an overall response rate of up to 45%. As first-line therapy, standard induction chemotherapy is no option for patients with high-risk MDS and is not included in the guidelines. Could we do this after AZA failure? We don't have any data for MDS on this topic, but we have learned a lesson from AML, and this Kaplan-Meier curve is the data from the registration trial for azacitidine in the AML population, and in this curve, you see the patient, the first subsequent therapy after study discontinuation. Study was discontinued by progress after either azacitidine or chemotherapy or conventional therapy. And as you can see, patients that relapsed after chemotherapy had a better outcome if treated with a hypomethylating agent compared to those patients that received chemotherapy after AZA treatment. Of course, this is conventional chemotherapy, and conventional chemotherapy is not the best option for high-risk MDS because of the cytogenetics lesions that are underlying, and the patients do not respond very well to chemotherapy, but you can think of new chemotherapeutic agents that may become available and change the situation. One of these compounds is vosaroxacin, which is a new anti-cancer quinolone derivative, integrating agent and DNA topo-2 inhibitor, which is supposed to have reduced cardiac toxicity, important for this elderly population. We should be active independently of the p53 status and should evade P-glycoprotein receptor and have no MDR efflux. We have randomized data recently published in Lancet Oncology in relapsed refractory AML patients as an add-on to cytarabine. This was a randomized trial where the primary endpoint overall survival was not met, probably due to the high rate of allotransplanted patients. But subgroup analysis show a possible benefit in elderly patients, and therefore this drug is being tested as a single agent in high-risk MDS and could maybe become a new chemotherapy option for MDS high-risk patients. Targeted treatment, you have seen both these curves before, yesterday and also today. These are the different genetic lesions that you can find in MDS. 2 large series that have already been discussed. The problem is that you have a very heterogeneous picture of the genetic landscape, and you have a lot of patients with very rare genetic aberrations that makes it really difficult to design new treatment. And I will discuss at the end of my talk that we maybe need new approaches to the design of clinical trials to face this situation. So a cartoon I've taken from a recent review from Montalbán and Garcia-Manero about possible targets and enriched for some additional targets. So you see you have quite a list of possible targets and agents that are working on these targets. Some have already been discussed, luspatercept, for instance. Some have been tested years ago with not so good success, but maybe it was that not the right patients did receive the right treatment. And you can also see that some of drugs you know from other diseases, from myeloproliferative neoplasms, and also from myeloma, for instance, are being tested in MDS. The first one that I would like to discuss, because there are randomized data at the moment, is rigosertib, which is an inhibitor of the PR3 kinase and polo-like kinase pathways. And 2 or 3 weeks ago, there was a publication in Cell elucidating the mode of action. Rigosertib acts as a RAS mimetic, disrupting the binding of effector molecules of RAS, and as RAS is a very important pathway in MDS, this could be a very important approach. Rigosertib induces mitotic arrest and apoptosis, has to be given presently by continuous infusion. An oral drug is being developed, and this slide shows the phase 1/2 data, where we have considerable response rates, and favorable toxicity was demonstrated. After this first phase 1/2 data, there was a randomized phase 3 trial conducted, which was reported in the Lancet Oncology also a few weeks ago, the publication. And again, also in this study, the primary endpoint, which is overall survival in a comparison of rigosertib versus best supportive care in patients that failed hypomethylating agents, was not met. There was no significant difference. But in subgroup analysis, there was a difference for patients with primary failure and also in the IPSS-R very high risk group. So these are the forest plots for all the possible parameters for response, and I've depicted the most important ones. That is the type of HMA failure, primary failure, would benefit from rigosertib, the IPSS-R risk group, and also high-risk cytogenetic patients should have a benefit. Coming from this data, there is now an ongoing phase 3 trial of rigosertib versus physician choice in primary HMA failure with stratification for the other risk factors. And in the US, the first patients have been included, and the first 2 European patients have been included in Austria in the last 2 weeks. Checkpoint inhibitors are a topic that is very hot and discussed in many fields of oncology. Why should we use checkpoint inhibitors in MDS? The rationale is that the expression of the targets is enhanced by treatment with hypomethylating agents, and there is a possible implication that the activation of the checkpoints is implicated in the treatment failure of hypomethylating agent, and therefore if you do a checkpoint inhibitor, you can overcome this situation. At the last ASH meeting, there was a report of a phase 1 trial of ipilimumab following hypomethylating agent failure. Of course, phase 1, only 11 patients reported. Monotherapy tolerable, can lead to prolonged disease stabilization, and also allogeneic stem cell transplantation appeared feasible. And the authors concluded that this provides the rationale for further exploration of immune checkpoint inhibition therapy in MDS. Another target is Birinapant. Another target is apoptosis, and there are inhibitors of apoptosis that suppress the apoptotic cell death. And for these inhibitors, there are antagonists, the SMAC, second mitochondrial activator of caspases, and Birinapant is an agent. This is a potent bivalent SMAC mimetic, and also early study reported at last year's ASH, 21 patients in AZA refractory in combination with azacitidine. There were more severe injection reactions. We have to learn about these new drugs, otherwise acceptable toxicity, and has clinical activity. And again, patients could be bridged to stem cell transplant. I could go on with a lot of other drugs that have been tested, that have shown some activity in phase 1 and phase 2, but the general problem is that we need to identify those patients that benefit from a certain drug, and I think we need to change the approaches with this setting. Single agent treatment could be not the best, and the first approach is to use combinations, and I would like to show you two studies with combination treatment. Again, one study which was randomized, the azacitidine combination with lenalidomide or vorinostat against the monotherapy of azacitidine. The basis was a phase 2 study with very promising results, and again, the combination was disappointing. It was the AZA standard dose combined with lenalidomide 10 milligrams per day or vorinostat 300 milligrams twice a day until progression, quite a large trial. But in the protocol, there were dose reductions allowed, and a lot of patients had dose reduction and did not receive the planned dose. And this is reflected also in the results. First of all, one idea was that you get a faster response. This is not the case, as the median time to best response is the same, and there were no significant differences in response rates. The only point that we can learn from this trial is that patients that reach a response have prolonged relapse-free survival. That means if you delivered a full dose and get better results, then you may have sustained responses. One other combination trial that I've selected due to the high rate of CR reported, of course it's a phase 2 study with only a low number of patients, is a combination of cytarabine or decitabine with tosedostat, which is an oral aminopeptidase inhibitor. If you go to the website of clinicaltrials.gov, you find that most of the agents are being currently tested in patients with hypomelectic agents failure. But what we're doing? I think what we do is that we use one drug for patients that look similar, they look the same, but if you look closely, they are a little bit different, and also even we look the same drug in really different patients. And I think that we need to change our approach to the heterogeneity of the disease. First of all, one possible approach is to identify druggable targets that are common to all MDS patients, and I think that the success of hypomethylating agent is that disturbed methylation is common to all MDS patients. Splicing apparatus could be another druggable target that is common to all MDS patients, and you heard yesterday from Mario Cazzola that there are some efforts in this direction. Second point, identify predictive markers. And the last point is develop new design for clinical trials. Predictive markers, we have learned a lot, and those are the predictive markers that are established. EPO level for EPO response, 5Q for lenalidomide response. And the question is, can we move on further on this? Can we use the data from next generation sequencing? And again, there is one abstract, one presentation from last year, ASH, that will show briefly. There is what an American group, Medina et al., showed and proposed was to take data from 3 prospective studies where you have all the clinical data, all the response data, and where in addition the next generation sequencing data were collected, and then to make a model, computer model, and to predict response and to compare if the predicted response was the same in the real patients. So this is a computer model based on published literature and all the information available on interactions of molecular processes. Then comes the input from the patient with genomic aberrations, possible drugs to be used and drug interaction, and then to develop a protein network map. So what are the results? Response rates that were known from the clinical trials, and the prediction, the percentage of correct prediction that was possible in this study. Then the percentage is dependent not only on the correct or wrong prediction, but also on the available material and the available prediction. So you see from 30 to 80% there was a prediction possible, and this is the correct prediction for responders and non-responders, ranging from 45% up to 100%. And one example taken from this abstract, a patient that responded to lenalidomide and this response was predicted. The patient had an alteration in the casein kinase 1 and had normal p53. You heard already from Thorsten Haferlach that this is going to be a lenalidomide responder, but this is not a part of the story. You have a lot of other aberrations as well. So how to move on? How can we get more data? And I think that we need a change in the design of clinical trials. The classical randomized phase 3 trial is inefficient, involves a lot of people. The test is given at random and is problematic heterogeneous diseases such as MDS and with targeted approaches. What we do in real life, outside clinical trials, we know about an intervention, we give the patient the intervention, then we monitor, and if it's effective, we go on, and if not effective, we make another intervention. You could also do this with clinical trials, and but you need a whole apparatus of formalizing and scaling up this. So you need to have different numbers of centers that have all the different agents available, and I think this requires a cultural shift on many levels, and also both on the side of regulatory agencies, pharmaceutical companies, and also in the clinic. The 2 types of new trials that can be seen are one had umbrella studies where you have one single diagnosis, then you have a genetic analysis of the patient, and according to this analysis you make different interventions. And on the other hand, you can basket studies where you have one intervention and take patients with different diagnoses. And all those types of trials are already going on in solid tumors, and we are having these types of trials in AML, and I think we need to have this implemented in MDS as well. This costs money. In the US, this is going to be spent. And come to the conclusions. What are future strategies? We need further development of new agents, single agents, combinations. We need to find the right patient for the right drug using precision medicine. We need, this is of course one standard phrase in all the talks, include patients in trials. And as a sort of introduction for the next talk, we need to transplant those who are eligible, since this is the only way to cure. We need to do early transplants. Patients after hypomethylating agent may become eligible to a transplant, and we need to improve treatment strategies. And with here I stop and thank you for your attention.